Hey everyone, thanks so much for attending and listening in today. We're going to talk about evolving and building out virtual care programs. My name is Chris McCann. I am the CEO and co-founder of Current Health. We are a global healthcare technology company headquartered in Edinburgh and Boston, and we work with a number of different NHS organisations throughout the UK, including the incredible Imperial. And I'm really delighted to have James join me today. James, maybe let you introduce yourself.
Thanks, Chris. I'm James Bird. I'm the Chief Nurse Information Officer at Imperial, covering 5 hospital sites in northwest London. I've got an emergency medicine background, and I'm here today with Chris to talk about some of the work we've done with Current Health and the remote patient monitoring streams.
So we thought today, firstly, I'm going to give just a very brief 2-minute overview of Current Health and what we do. James will give an overview of Imperial and where they are looking at virtual care and remote monitoring. And then we thought we'd just have a discussion and hear, hopefully mainly from James, about both the good and the bad and the lessons learned around virtual care and implementing and using Current Health in some of those programs. Firstly, very briefly about us. We try and provide our healthcare partners with one common mission control for all healthcare delivery outside of the hospital, from the highest risk, highest touch, most complex and acutely unwell patients in the home, through to the lowest risk and lowest touch patients, providing configurable monitoring, configurable data acquisition for patients, depending on what's appropriate to their clinical needs. We firstly focus on solving data acquisition from the patient at home in a way that's relevant to the individual needs that they have, ranging from continuous monitoring of their vital signs from a little Oreo-sized device that they wear on their upper arm, to patient-reported symptoms through an application that we can give them on their own phone or on our managed tablet, to integrations with a wide range of other devices from other manufacturers, so we can really tailor that monitoring to what's appropriate to both acuity and therapy area. That includes things like Dexcom for continuous glucose monitoring, through to weight, through to things at the moment that we're doing like ECG. We then focus on taking all of that data, assimilating it and analyzing it to try and identify who is the patient that's most in need of treatment, who is at risk of disease onset or disease progression, and getting that actionable insight into the hands of our clinical partner as early as possible so they can see and treat that patient. We're also now starting to stand up our own virtual command center to really act as an operational extension of that NHS organization, and our team will do some of that initial assessment and treatment and triage, and then escalate back. The other thing we're now starting to do is integrate with both local and national partners who can actually go out and go into the home, or can bring out and deliver home equipment or medications, and truly offering and working with our partners to deliver end-to-end clinical pathways, and at all times trying to integrate it back to the electronic health record, so there's no data silos and everything works together. So now I'll hand back to James, and James will give you a little bit of an overview of Imperial.
Thanks for that, Chris. So Imperial College is, as I said, a 5 hospital site that sits in northwest London in the United Kingdom. We have approximately just over 1.125 million outpatient contacts a year, just under 300,000 emergency department attendances, which are based in 2 emergency departments at St Mary's and Charing Cross Hospital. We cover 8 local London boroughs, and as you'll appreciate, for integrating care seamlessly with social care, that actually presents quite a significant challenge. We've just got over 1,100 beds in our acute system spread across those sites. The mainstay is on 3 of those sites, which have got about 375 beds on each site. And then there's the Western Eye Hospital, which has only got a very small ward on it. And of particular interest today, we've got in the care homes around the St Mary's Hospital in Paddington, we've got over 1,300 patients who are in care homes. So these are care home residents, either nursing or residential homes, who are in residential care homes around the St Mary's campus, and whose care, when they deteriorate, will result in them coming into the St Mary's emergency department. When we started looking at what sort of technology and what sort of things that we were looking for to do continuous monitoring, we set ourselves some sort of standards and things that we would consider when we were partnering with organizations. So in this particular instance, it was absolutely essential that it was continuous monitoring. So we weren't asking for patients to enter data once a day. It had to be a continuous mode that the patient, or a device the patient could just wear, and the device and the information, the vitals information, will be seamlessly transmitted to the dashboard that we will be looking at. EHR interoperability was the next key thing. So we absolutely don't support in Northwest London siloing of data across platforms. So if you are a company that wants to come and play with us in Northwest London, we absolutely, it has to link into either Cerner, which is our EHR, our in-hospital EHR, System 1, which is used across the majority of our primary care. We have got some other systems, but most of it's System 1. And or into the patient health record. So we have something called the Care Information Exchange. It's the patient personal record. And so what we've done with Current Health is we've linked to the data that is coming through on the monitor that we see, also ends up in the patient's current health record. So the patient sees as much as we see about their vital signs. It was also essential that we have one place that we could go to configure these options, one platform. So we absolutely don't want multiple places for people to log into, particularly clinicians. So it's absolutely essential the clinician's workflow doesn't involve yet another username, yet another password, yet another app. So those were the key constraints that we have to put around systems that we work with. And it needs to integrate seamlessly with the patient. So it can't be hard for the patient to use the tool. We've got a wide range of patients, and I'll explain some of the pathways we're using at the moment shortly, but we are, it's got to be easy for the patient to enter the data, and for that data to then inform the care that we're doing next. So we're very keen that when we use remote monitoring, it should do one of 3 things to a patient pathway. So we're either aiming to reduce emergency department attendances because we're looking after you in the community and escalating before you would deteriorate to the point where you need to come to ED. We're either doing that, or we are reducing your outpatient attendances. So it might be, for example, we are doing it with our renal transplant population at the moment, and by monitoring their blood pressures post-renal transplant, we're able to adjust the patient's medications remotely without asking them to come for a clinic review every couple of weeks. The third way of doing this is to reduce the inpatient length of stay. So if we've got our TAVI service in our cardiology suite at the Hammersmith, and those patients would normally have a length of stay of, say, 4 days, but we're able to cut that down to 3 days or 2 days, because actually the last day of monitoring is just routine blood pressure monitoring on the ward. And actually we can safely do that at home, as long as the patient hasn't had any untoward, adverse events in the first couple of days. We can actually cut that monitoring day that we would normally do, and we still need to do for safety, that can happen at home. So the patient actually gets put on the monitor in the ward and goes home with their kit, and we then do a few days monitoring at home to complete their episode. So we're looking how it has to integrate into the patient's pathway. But most importantly, it's not just it integrating, it must make a change in the patient's pathway. It's not just another tool or another toy we can use. actually this must transform the patient's journey through our care system. And that's back to yourself, Chris.
Thanks, James. That was great. And firstly, can I just say thank you for being such amazing partners and for also agreeing to do this today and sharing your experiences. Can we maybe dive right in? And I'd love to first touch on the frailty team. You know, the onset of the pandemic, your frailty team very, very quickly implemented a virtual care program to support, you know, some of the high-risk patients within care homes that you just touched upon. Can you maybe start by, you know, describing that program a little bit and what you were hoping to do and achieve?
Yeah, absolutely, Chris. So I would love to be able to turn around and say it was a planned event, but unfortunately, as everyone will be aware, the pandemic offered different opportunities. So we'd originally procured the current health monitoring for our bariatric service to reduce inpatient length of stay and post bariatric surgery. But obviously, with the kickoff of wave 1 of COVID, all elective surgery was cancelled, and all of a sudden I had 30 monitors with nothing to do. But I then also had a frailty service that was charged with keeping as much of their frailty patients out of hospital as they could in the care homes, whilst also supporting those patients in the care homes. And it's a small service. It's got half a dozen practitioners who go into the care homes around the hospital. And I knew the manager quite well, so I reached out to her and said, I've got some monitors. Actually, if you want to, we can roll this out into your service. We had a bit of a demo and she went, right, we're having 20 or 30 of these. And within a day, we'd rolled out to the care homes all these monitors. And what it allowed us to do, so it's not the monitors themselves are not the golden bullet. So the monitors facilitated the nurses who were going into the care homes anyway to provide that safety net to the care homes, that they were able to provide the safety net more than just their physical presence in the care home. So they could go into the care home or go into multiple care homes, instigate the monitoring, and actually teach the staff how to instigate the monitoring on their own patients. And then by doing that, they could then come back to the hospital and review the patients, and they could even review them via the dashboards on their way round their care homes. They were able to advise the care home staff of what was happening with their patients. They were able to obviously access our core EPR, where all the discharge information, previous test results were. So there were some patients where some of that, because we hadn't done the discharge summary correctly to the GP, some of that information was missing. And actually our practitioners were able to do a set of obs with the remote health, monitor for a couple of days, look at that in the context of what their observations and blood results and investigations and x-rays had been as an inpatient, and then actually advise the staff where to go next. So we, as you say, Chris, we quickly ramped that up. So the frailty service went big bang very quickly. It was June, July last year. Once we looked at it at the other end, we know that frailty patients, should they come to ED, have over an 80% what we call a conversion rate. So a frailty patient coming into ED is likely to be admitted from a care home. So we know that's the case. So ideally, if we can manage them in the care home and not bring them into the ED, that is to their advantage, and it's also to a system advantage. We rolled out the kit, started using it. We found that of the patients whom we put the remote monitoring on, 87% of them didn't then come to the emergency department. So we were able to utilize the data we were seeing in the remote monitor to then make a decision or provide advice on the next steps of the patient's care, and didn't need to bring them to the emergency department. There were some that still needed to come. And so it's important to say that it doesn't stop all attendances, absolutely shouldn't. It allows you to triage them and then advise on the best pathway for that patient. So we then looked actually what would have happened had those patients, that 87%, had they come to the emergency department. Well, actually, we know that 80% of them get converted to an inpatient. We know what their average length of stay for someone or a frailty patient is. So we actually worked it out, we saved 144 bed days, which is broadly aligned, obviously 400-ish pounds per day per bed is about 62K's worth of savings, but it's a system saving. It's not a saving to the individual organisation. This is an improved patient pathway not necessarily an improved cost to the organisation. It certainly did help us with our bed flow at that height, or just as we were coming off the height of one of the pandemics, because all of a sudden these patients weren't streaming through, and these are very vulnerable patients. So obviously they would come into an emergency department, which, as most emergency departments were, you would have a red or a COVID stream and a non-COVID stream. But actually, if you're generically unwell and we're not too sure what's going on, you generically went down the, a lot of the times you went down the COVID side. And obviously the chances of these patients getting COVID and then dying from it is actually quite high. So not bringing them into the emergency department was a massive win for the organisation. But whilst providing that support to the care homes in a way with remote monitoring stuff that is not their normal bread and butter. So it absolutely relied upon our nurses being part of the equation, not just putting the monitors into the care homes, because just putting the monitor in won't do anything. It's not something they're used to using. It's not in their area of practice. So our nurse had to go in to support that, as they were going in anyway to support the environment, but it gave them another tool to support in that environment.
Yeah, I mean, I love that, because I think certainly my view is that technology is an enabler. You know, it can't operate without the nurse, without the doctor, without the clinical model around it. All it's doing is empowering or enabling a clinical model to be done slightly differently. So I couldn't agree more. What was the, you talked about it not being the bread and butter of the care home. What was the feedback and position like from the care home staff?
So it was actually really encouraging, because the practitioners who were going into the care home had that existing relationship with the care home. You were trusted to go in there. The frailty team were trusted to be in there, and when it was here's something else which will help us help you, it was a trusted relationship. Now that relationship had to be built, and thankfully we were lucky that relationship was already there in the care homes that surrounded St Mary's Hospital. So we were able to exploit that relationship to the benefit of the patients. Certainly, if we hadn't had that relationship, it might not have been received quite so well. But certainly, you see on the screen the 92% adherence rate. So this is actually, we were getting patients who were adhering to the monitors, but obviously a lot of these patients weren't putting the monitors on themselves because they are frail patients in a nursing home. They're getting complete nursing care. So actually it's the staff that are instigating this. And we had many instances where the staff would instigate the remote monitoring themselves. So they would ring up. So we also had a hotline where they could call us. So they would ring us up and say, Mr. Jones, I have started him on remote monitoring. I've attached him to the monitor. Can I talk to you about this patient, because we're a bit unsure. We don't know where to go. Do we need to send him to the emergency department? Can we wait till tomorrow for the GP to come out, or it's the weekend? What's next? By having that relationship there, it made it a really good experience for the care homes. It could easily have been very different. I think it could very, because you're right, Chris. It's just technology, and if you're shown and something is thrown at you, it becomes oh, I don't really want to do this. I just want to carry on working the way I've worked. Actually, they really embraced it really well.
Do you think, I mean, looking at this pie chart and the fact that, 44% of interventions were almost collaborative working between the nursing team and the care home team on how to manage high risk patients, do you think this will change the almost the way of working going forward, that there's almost this kind of educational process between the health system and the care home?
It's entirely possible, and absolutely there's obviously a lot of things in play in the remote, both in the remote monitoring and the care home sectors at the moment. Certainly, because you're right, if we look at this pie chart, there is a number of things obviously we did. We obviously did work collaboratively, and that's the big chunk. 44% was actually the practitioner who's going into the care home working collaboratively with the staff to work and manage those high-risk patients. And that comes from both that practitioners, so our practitioners have all done their advanced medical assessment skills, so they're bringing a level of practitioner grade assessment to the situation, but they're also able to access all the previous notes, which the care home can't access.
Yeah.
So there's a whole range of tools that work in there. I would love to think this will continue, because it's shown such a good way of working. it's not there to replace the primary care network, and that's the key piece here. The GPs that are linked to the care homes are still the GPs that lead the care in the care homes. This was all around adding something to that equation rather than taking something away from that equation. We found that actually some of our care homes, which had the best GPs, really embraced this the most because the GPs were so into it as well and actually saw it as a tool that they could access. So some of our GPs got access to the remote monitoring dashboards. So it was a very collaborative approach. Some of the parts around where we most were influenced without the GP was out of hours though. So as soon as it came into an out of hours setting, that was when the frailty team had a bigger impact because they were able to talk through stuff. The care wanted to talk to someone, and actually we were still around. The other bit that we did with our care home staff was we, obviously being the main receiving hospital for these care homes, knew when we'd sent patients back to the care home. So we would proactively go and say, how is Mr. Jones? We discharged him to you yesterday. We know you've got him. Can we follow up? Is there any questions on the discharge? So it was proactively, even before we deployed the monitor, we were proactively chasing both the patients that we know we've just sent the care home and also the ones that we know are slightly on the edge because actually they may be deteriorating. And when we visited the care home the other day, you mentioned this patient, so let's follow them up on the telephone conversation. There was a piece obviously about referring on to other clinicians and other parts of the MDT. So you'll see in there 6% got referred on to physiotherapy, 6% of them were emergency admissions. So of those patients, 6% were just this patient is sick, they need to go to the ED, get the ambulance now. And actually that worked really well because it was appropriate escalations to the ambulance service. And that conversation with the ambulance service was along the lines of, actually, we've escalated this to the practitioner. These are all the obs. The patient now needs to be in the ED. So actually, it was collaborative at all stages and actually allowed this different outcomes to be achieved.
I think the thing that I find most exciting from what you just talked about is the integration between like primary care, secondary care, and social care, and the benefits that you see to the patient when that's actually happening. So
yeah, and that's the key there, Chris, I think, is the integration that we've done with the care information exchange. So having linked both our GP systems and our CNIO, our electronic health system for the hospital, into the care information exchange, having the observations here flow into that space as well, meant that both the primary care and the secondary care clinicians could access effectively the same data. They could see the same patient picture, and actually it didn't matter who was on, whether it was 3 o'clock in the morning, whether it was 2 o'clock in the afternoon, didn't matter whether it was the weekend or Monday, irrespective, everyone saw the same picture. Yeah. And that's the key thing to breaking down what sometimes has been a significant barrier between primary and secondary care, is that we silo the information off into different systems. But as soon as we stop siloing that off and actually bring it onto a single page, it shouldn't matter whether it's person A or person B that gets involved in the patient's care to help optimize them. Actually, as long as there is someone there at the point the care home need it.
And I mean, Current Health operates in the UK and the US, and honestly, there's so very few examples we have of that integration between primary care and secondary care because of exactly the point that you just made. There's siloing between these two distinct.
And I think that will change as we're going forward, I think. So we've now got the ICSs. We've just done a whole piece of work about bringing some of our social care record into CIE as well. So now you can go into CIE, not only do you see the outputs from their hospital stay, you see the outputs, you can see some of the GP stuff, but you can also see the social care record. So the social care plan, for want of better terminology, is also visible in the same space. So as you break those barriers down, you do improve things. And I think across the country, we will now see this with the integrated care systems that we are establishing in every region. This will become the normal. This will be the expected level of integrated care in the future.
Yeah, and I think there's a huge amount of talk right now about the evolution of healthcare to be more outside of the hospital. But actually, I think the bigger thing, and you're sort of describing it here, is the evolution of healthcare to see the patient along the entire continuum, not just as an acute episode when they come into the hospital, but along that entire journey of care.
Yeah, absolutely. And as you know, we've done it in other areas as well. And that's the key bit, is having this continuum of care. We're not siloing you. And actually, that's what we don't want to do. We don't want to silo you. We want to join it up. And it is hard because previously these systems haven't really talked to each other, and the way they've sent information to each other has been very bland, if we would use that terminology. So sometimes it's a PDF or a printed thing that gets scanned in and it sits as a document, and you have to trawl through these things to find what the nugget of information you're looking for. Now that we're sending information at a discrete data level, we're able to do things with that data when it reaches the other end. So the OBS, as they flow, observations from Current Health, as they flow into CIE, sit in the observation section of Current Health. So I could see my blood pressure if I was a patient by going into Current Health, and I could see the tracked blood pressure over the days that I've done it. Now that is powerful because I can see that as a patient, the clinicians can see it, both in primary care and in secondary care. So actually, when I'm going to my renal team and saying, right, actually, I've just had a transplant, here is my blood pressure readings. And if I then go back to my GP, actually, they see the same readings. They see the same data. I'm not having to, it's not a, please keep a diary of your blood pressures and I'll see you in a couple of weeks' time. No, I can log on instantly and I'll see what your blood pressures are doing. And at some point, I would like to touch on our maternity service, because at the moment we've certainly used that in our maternity service to change their pathways.
I think that's a perfect lead in. Then, what other clinical use cases are you now exploring around virtual care?
So one of the ones I absolutely would love to talk about is our preeclampsia in our maternity service. So preeclampsia obviously is a risk during pregnancy, and we've got a protocol around what the blood pressure should be below, so 140/90. And what we're able to do is mothers who have demonstrated signs that they may be becoming preeclamptic and we need further monitoring of, normally under normal circumstances would come twice a week into the clinic at the maternity hospital. They would get their blood pressure monitored at home, they'd write those on a diary, they'd bring it in, we would look at the blood pressure and then decide where we go to next. Actually, with Current Health, we've been able to circumvent all that. So now they are having we post the remote monitor out to them. So we courier it out to their location. They set it up at home. So they haven't been to the hospital yet. We monitor them. They do their twice-a-day blood pressures. The midwives and our remote monitoring team can monitor that. Any patient which triggers comes in and the midwife looks at and the midwife calls them. But actually, there are also patients that the midwives then call and go, you don't need to come to hospital for your twice weekly check. I can see your blood pressures, they're fine. Stay at home, carry on doing whatever you're doing, because actually I know you're safe. So it allows us to have changed. So there's patients who would completely change their pathway because they don't need to come to hospital. They don't need to have that interaction. They're getting the right care, but they're getting better care. And it's care that fits around the patient's life. We'll all have remembered pre-pandemic how you used to have to take a day off if you needed to go in to see a hospital appointment or see your GP. Actually, with the pandemic, we've now got telephone consultations with the GP. Absolutely amazing. I can do it. I can schedule it in my diary alongside my other meetings. All of a sudden, we've got hospital consultations. Actually, if I don't need you to come to hospital for a physical examination or a physical test, and actually I need to discuss something with you, or I just need to monitor something, and I can do that through the Current Health system, why bring you to hospital? So with our preeclampsia pathway, we've had some really good success. We've had some really good success with our renal transplant pathways. So this is patients who've had the transplant, require monitoring of their blood pressure. And I touched on this earlier. We were changing them patients' medications remotely. We're even coming back to the hospital, go, right, we need to up your antihypertensives. We now know what your blood pressure is. Don't need to come here. I'm just going to change it. You take 2 tablets rather than 1. Done. And we'll carry on monitoring it for the next few weeks. That changed. There's a particular patient that occurred with was living miles away from our hospital because we are a regional transplant centre for renal. So he was living miles away. It would have been a complete day's event to come to our hospital, get checked out and then go home again. So he didn't come to the hospital. He had a 20-minute consultation on the phone or by video, because Current Health enabled us to know what the answer was without him needing to come. We've aortic valve, I said we've got our TAVI service, and that is doing both at-home monitoring and also facilitating early discharge, which is also what our acute medical pathways have done. So during the COVID wave, we've actually applied it to patients on the acute medical unit, and that's been a facilitator to getting them early out the door with our current health monitoring. And as we're moving forward, we're looking at other services. So we're exploring our stroke service at the moment, and there will be other services. There's almost no end of the services that could benefit from some of this. And as I said earlier, there's three pathways, there's three impacts this can have on a patient pathway, and it can have it in multiple of those, but it should do something different. So it should either discharge you early, reduce your ED attendances, or reduce your clinic attendances. And the four that I've got on the screen here have demonstrated, each have demonstrated one or more of those to improve the patient's pathway.
I think that one of the, because there's a lot of chat just now about will virtual care, will remote monitoring still be as big a thing? You know, I don't really want to say post-COVID, but post-COVID. I think one of the things that's interesting in it is the experience of the patient, and you touched on it a few times, that, you know, the fact that you had the patient in question who didn't have to come a whole day's trip just to get medications changed. I think it'll be interesting to see whether patients continue to almost demand these virtual care services because they've seen during COVID that they can actually get them and it's easier and more integrated into their life.
So I think they probably will. So I think, and it's going to be a great, I don't think we've leaped 5 or 10 years in the space of 5 or 10 months in the course of the last year. So I think there might be a slight rollback of some stuff, but certainly I think now when I contact my GP, I don't ring the receptionist and book an appointment. I fill in a form online and someone gets back to me and we have a quick online conversation. I don't need anything else. So for some people, this will absolutely be the right thing. There'll be some other patients who's absolutely appropriate. You need a face-to-face examination with your GP or in the hospital. And so it won't be the silver bullet. This is not the silver bullet, but it absolutely is here to stay. We're not going to go back to a place whereby it's good to bring patients twice a week to a hospital when actually I don't need to do that because I can see using technology what the answer is when you're at home.
Absolutely.
That isn't going to go. It'd be like removing Facebook, Instagram, and Twitter and going, yeah, that was an interesting experiment, but we're just going to get rid of those because we don't need them anymore. The tech is here and the tech will stay. The key bit will be how we facilitate it in our commissioning pathways, how we utilize this in a way that shows how it works and how the benefits realization. So, and that's the key bit. How do you get the benefits realization? So we've started looking at some of that work. It's complicated and it's not an easy ask, because how do you know what the impact is? You've applied it to that patient, they've gone home a day early, but how do you know they've gone home a day early? I mean, you can look at the average stay for a treatment function code. For the preeclamptic patients, you can look at how often they came into clinics, but actually you don't know, was it the remote monitoring that did that, or was it something else? Maybe they just weren't, their blood pressure wasn't high, they wouldn't have come in anyway. So sometimes it's really hard to pin down the actual changes. Sometimes it's really easy. We also look at, we also don't want to encourage variation in pathways. So whilst we want to know what our impacts are, if we've got something where it's working, for example, our preeclampsia pathway, we want to know that we're applying it equally to patients in that pathway. We don't want it to be a case of this cohort of patients gets it, this cohort doesn't. So we are also in a position where we want to articulate the patient group. In maternity, that's actually really quite easy. They're all pregnant. They all have a blood pressure of over 140 over 90. That's it. Brilliant. They are the preeclamptic pathway. Aortic valve replacement, again, really, really quite obvious. We've just had surgery. Renal transplant, again, is a very obvious. But there'll be some where it's not quite so obvious how to articulate the patient cohort, that what we're referring to at the moment is the missed monitoring opportunity, the ones which we could have actually improved their pathway but haven't. So as we go forward over the next year, we're focusing a lot on the missed opportunity, because actually it's all very good, the ones we're doing, and that's brilliant. It's absolutely brilliant work. But unlike inpatient care where I have to have a set nurse to patient ratio. I can't do over X. I've got 130 monitors. I can have 130 concurrent patients. And actually, because of the way the dashboard that Current Health has got is organized, all the acuity ones just fall to the top. So actually, my nursing staff, I can have 1 or 2 nurses looking after that 130 patients. They're in their own home. As a patient, it's always better to be in your own home than hospital, because there's no way hospital is more comfortable than your own bed. And your food is always better than hospital food. So you want to be at home. So I would want to be at home if I'm safe to be at home. If I'm sick, and this is where remote monitoring isn't like the absolute silver bullet to everything, because if I'm sick, I should still be in hospital. So remote monitoring and the way we run it isn't overnight. Because actually, if you're sick enough to need me to monitor you overnight, then you should be in hospital. Because actually, normally, if you were sick overnight, you'd ring the ambulance service, and that's fine. And if that is a reasonable escalation pathway, which if anyone was sick, they'd ring the ambulance.
Yep.
That's fine, or come to the emergency department. That's what you should do. So actually, if you're so sick that I need to sit there and watch your sats and pulse overnight, then actually you need to be in the hospital. You're not well enough to be at home. So it doesn't solve everything, but it definitely moves a cohort of care back across that primary-secondary divide, and probably puts them somewhere in the middle of the primary-secondary divide in this new third space that we're developing. But effectively, that's where we're coming to at the moment. So I do see it continuing. I don't see this disappearing now.
I love the focus you have on the pathway, because I think, I get the privilege of seeing into lots of different organizations and how they do this. And I think there's some organizations who do see technology as the silver bullet, and they throw out technology without considering the pathway. And then they're confused when they don't achieve any benefits whatsoever. And then there's another group of organizations like yourselves who they almost look at how can we reimagine the care pathway because we have something here that can allow us to do it differently. And those are the organizations that then see the benefits.
I think it's challenging doing it the way we've done it, and certainly it's not grown as quickly as I would like. I'll be absolutely honest that it absolutely hasn't. But that's because we're going, rather than just throwing 130 monitors into the wind. So we are targeting specific pathways. We're also not doing, so some organizations I know, if we would get 100 monitors, we'd go, right, those 30 are for frailty, those 20 are for respiratory, those 10 over there go that way. And whilst we worked out how many we'd need based on sort of roughly what services we'd use, we don't give the services their own monitors. We hold it all centrally. So we use a hub and spoke methodology to our monitor deployment. So actually, if frailty wants to use 30 monitors today, but then wants 50 monitors next week, that's fine, because I can give them those 50 monitors. Because actually respiratory, we're approaching the summer months, respiratory aren't using theirs. So rather than it sitting in a cupboard for the summer months when respiratory don't need it, and they only need it during the winter months, then actually it's used somewhere else. And actually in the winter months, when we're doing less elective work and we're doing more emergency work, actually that's fine, because I move the monitors back into the other space that needs it now. So we've absolutely taken a hub and spoke model. And what you can see on the screen now is sort of how we've sort of done it. So I've got a dedicated logistics manager, and if I could give a nugget of sort of advice to people, it would be to have someone who does this. They're the person who is responsible for getting the kit out to the patients, getting the patient registered on the right kit so the kit arrives preloaded with all the patient's details on it. They do all the courier, they organize all the couriering back, both there and back. Should any of the kit fail, they order the replacements. When the kit does come back, they do the recycling of the kit, the cleaning of the kit, then goes on the shelf ready for the next one. So all of those stages of doing that is taken off the clinician's hands. So what we don't want to do is, I don't want very highly paid clinicians to be doing logistics and worrying about moving people and kit around. That's not what I'm paying that highly paid clinician to do. Their use is as the clinician. So actually what we've done is we've got this dedicated logistics manager, and that leaves the clinician to do the clinician piece. So when my nurses do their remote monitoring review, they're not having to worry about anything else other than what is the patient's OBS, Do I need to escalate this? Do I need to have a phone call with the patient? Those are the considerations they have. It's not how do I get the kit there? How do I set it up? The logistics side deals with all of that. So actually, over the course of the remote monitoring period, we've split out the functions, and that allows us to do it across 5 hospital sites, and sending kits. Sometimes it feels to the 3 winds, but we are sending kits all over Northwest London to achieve this, and it's actually working really well. You have that monitoring and triage treatment piece, and what we've got on the screen now is potentially where we could end up with this in the future. So we absolutely want to, as a goal, as an aspirant goal, and we're not there yet, as with everything, it sometimes moves slowly, sometimes moves very quickly, is to have a centralized monitoring hub. So at the moment, the care for those patients remains under the care team that they're under. So if you're respiratory, the team that is looking after you is still looking after you. When you go out to teams, then often you get a pushback, go, oh, this is more work. And it perceives itself as more work. It absolutely does. But I would turn around on its tail and go, actually, it's probably not more work. So if you are the acute medical team, you have X number of patients. Renal transplant has X number of patients. Now, I can either look after X number of patients, in the case of the acute medical team, on the acute medical ward, sometimes in the corridors, sometimes in ED, or I could look after them all just in acute med and have some at home that I'm doing some remote monitoring on. Renal transplant have X number of patients. Whether I look after them all in the hospital or some in the hospital and some at home, the number is still X. So actually, it's not creating more work for me. And actually, rather than running around the hospital as the acute medical team, trying to find where all my patients have been placed on various wards and corridors, if they were all on my ward in the acute medical ward, that's amazing. It means I've got a cohort of patients I can see physically in front of me. And I've got a cohort of patients on my remote monitoring dashboard, all of which are under acute med. They would all be under acute med if I kept them all in the hospital. All I'm doing is reducing my stress load, because I've got the ones I can safely manage remotely being managed remotely. So what we want to do is eventually have that central monitoring hub. We're not there yet. That will relieve some of the day-to-day monitoring from the clinical teams responsible. So actually, the acute medical team wouldn't have to watch those 10 or 20 patients they've got at home. Actually, the remote monitoring hub would watch them and would escalate to the medical team, right, these 6 are out of kilter at 3 o'clock in the morning. What do you want to do about them? That's a future development. That's where we want to go, and certainly that's what they're doing in some areas of the States. But that's aspirant, and we're not quite there yet.
I mean, it's been incredible to hear, I guess, both your journey and also your vision for the future. I guess to finish up, I'm curious to learn, what hasn't went well. What should companies like mine do better, and what lessons have you learned that maybe you would want to share with others who are thinking about standing up these kind of programs?
Yeah, as with anything, so it has been a journey, and there are bits that we've learned along the way. Certainly, our product, as I've said, integrates into our patient portal, and that works really well. And it works really well until either Current Health or the CIE vendor then does an update that we don't quite know about, and then unfortunately the integration then stops for a period, which we didn't realize that was a thing. No one thought that was a thing until we were in the middle of patient monitoring, and all of a sudden connections dropped and we couldn't add new patients. It was a learning experience. When, okay, right, what have we done? Okay, right, so one of the organizations did an update. Okay, right, so we now need to know about those things. And that was the learning. It wasn't the fact that the updates have happened, because actually system updates do need to happen. It was more the fact that this caught us unaware. So it was more actually a case of, that was the key learning bit. It was if you're going to integrate this, you've got to be aware of the dependencies of that integration. And sometimes, and I sit on the IT side, and sometimes we are very guilty of this. We sit on an IT side and we go, oh, we're just going to upgrade this thing over here. None of you clinicians need to know about this because it's IT. Don't worry. It's all to do with the HL7 messaging. And as soon as you mention HL7 or Smart and Fire, clinician eyes just glaze over and they're like, yeah, not interested. You've just bombarded me with rubbish as far as I'm concerned. But actually the translation of that, which is the key bit that like CNIOs and CCIOs do, is actually the clinical impact for this will be you'll have an outage of monitoring at this point lasting about 10 minutes. Okay, right. I did need to know that because that will affect, I don't need to panic then when that happens. Right, it's expected. So that was certainly an experience we had early on that we are glad we had early on, and we are glad we got to the bottom of. And also, as in any evolving relationship, there has been challenges, but actually we found Current Health being really good at responding to those. So we initially went live, and in our initial design, we put everybody in a single bucket. So because why would you not want to see all your patients on one screen? And when we first went live with the frailty team, that was fine because every patient on the screen was frailty. So that was easy. We then went from 30 monitors to 130 monitors and then went out to other specialties. And all of a sudden, we had every patient from multiple specialties on a single screen, which is fine if you're the remote monitoring hub because you want to see them all. It's not fine if you're maternity and you absolutely are not interested in what's happening in the care home. And likewise, the care home is not interested in what's happening in the maternity suite. So that was, again, a design consideration. The way we built it the first time out the door, we then had to do a lot of rework to go and build it in a way that supported multiple services. So I suppose the advice there is, if the eventual goal is to go to multiple services, even if you start off in one space, build it for the eventual goal. Don't build short term.
Yeah, absolutely.
So I mean, those are the cool couple of nuggets that I suppose I encourage people to take away with. It takes longer than you'd think to roll it out, and sometimes longer than you think to get clinicians to engage with it. There's always some clinicians that go, absolutely, I can see the vision, this is the way forward, and there are some clinicians who are like, I want the patient in front of me, and that's fine. And both of those are reasonable parts of the spectrum to be on. I initially went, oh, it's fine. These monitors will fly off the shelves. Yeah, I'll have 130 of them, please. And it's taken me a lot longer to get them all used than I thought it was going to take. Because changing, yes, I could have just stuck them out there in the services and gone, yeah, I've deployed them all to the respiratory, I've got 30, cardiac, I've got 20, we're done. Actually, to get them to use them and to change the pathway and actually have that utilization, it was a longer journey. But the results you get at the other end are better if you go through that pathway journey rather than just dumping monitors onto people. I
could not agree more. And again, I just want to thank you for, firstly taking the time to do this, and also just being such incredibly good partners and so visionary in your way of thinking about the future of this. So thank you for taking the time today, James, and sharing your experiences with everyone. I've certainly found it informative, and I'm sure everyone else will as well.
Thanks to yourself and Current Health, Chris. It's been a good partnership throughout.